Welcome to Sign Out with the Professor. I'm Dr. Lewis Hassel, and we'll be beginning our program very shortly. So we're very happy today to have one of my dear friends and former students, Dr. Paari Murugan, who's now Assistant Professor of Pathology at the University of Minnesota, joining us as our guest professor. Paari came very highly recommended to our program in Oklahoma, and we identified that his strengths would be very, very strong from the very beginning. And he is truly someone I consider a star in pathology, and I'm glad that he's with us. After he finished his residency at the University of Oklahoma, he went on to do a fellowship in New York, I believe, at Sloan Kettering.
Yep.
And now is in practice and teaching in Minnesota. So Paari, you can tell us more about yourself, and when you're ready to begin to share your slides, please go right ahead. You're able to do that.
Yeah, thank you, Dr. Hassel. So I did my residency at the University of Oklahoma, as Dr. Hassel mentioned, under his tutelage. He's a great teacher, a fantastic mentor. And currently I'm practicing in a large academic center, the University of Minnesota. As Dr. Hassel mentioned, I finished a fellowship at Memorial Sloan Kettering in genitourinary pathology, and also at the MD Anderson Cancer Center in general oncologic pathology. Here at the University of Minnesota, I mostly practice genitourinary pathology and also soft tissue bone pathology. So when there's an opportunity, I will probably deal with some soft tissue bone cases as well, perhaps sometime in the future. Well, thank you all for being here. So we should go ahead and get started. Today, I was planning to speak to you all about some urologic pathology, specifically bladder pathology. So I won't go into a lot of complicated or esoteric cases. In this particular session, I thought I would begin with some basic diagnostic features that we need to use, or essentially our approach to bladder pathology. Okay, so let me start by sharing my screen. All right. So I believe all of you had an opportunity to review these cases. So these were put up online, and hopefully you can all see my screen right now.
Yes.
Yes, okay. So we can go ahead and get started with case one. I will mostly be talking about bladder lesions that have a papillary architecture in this session, and perhaps in future sessions we can talk more about the flat lesions. But this particular hour will be dedicated to papillary and some related lesions in the bladder. So this patient, as you can see, is a 45-year-old male who was found to have a solitary papillary lesions in the bladder. So the word solitary is somewhat important over here, because oftentimes, as most of you might know, bladder lesions tend to be multifocal. They have the so-called field effect, which causes the propagation of multifocal tumors, not only in the bladder, but also in the ureters and sometimes in the renal pelvis as well. But solitary tumors do occur, and when we see solitary tumors, it brings up some differentials in mind. Let's talk a little bit about this one. So here you can see from a low power, there's the bladder surface, the urothelial mucosa, which looks quite normal. And then there's an obvious exophytic proliferation. This exophytic proliferation is in the form of papillary fronds. So we call them papillae, obviously, because they have the central fibrovascular core, which is surrounded by a layer of epithelial cells. So you can also see that there are these numerous papillae, and most of them are fairly delicate. by delicate, what do I mean? What I mean to say is they're all distinct, and they have this thin layer of epithelium covering them, and they are not as coalescent, right? So most of them are separate from each other. Maybe you do have some trying to coalesce with each other like this. Perhaps there's a tangential sectioning over here, but most of them are delicate. Most of them are thin papillae, and most of them are separate from each other. Okay, and clearly the other feature that we see is it is an exophytic growth pattern, meaning it's not going into the lamina propria, but it's growing outward into the lumen of the bladder. So what are the other features we can note from this magnification? So you have a nice comparison of normal urothelium over here. You can see that this is the just about normal thickness of the urothelium. So you can get up to 4 to 7 layers thickness. And if you look at the lesion itself, you can say that its thickness is somewhat similar to what we saw, what we see in the normal urothelium here. So anywhere you look, it's all having the same, maybe 7 layers, perhaps a little bit increased in some areas as you go around, maybe a little bit increase here or somewhat increased here, but this could just be tangential sectioning, right? So we got that fact. And then the other feature that is very prominent, even from this magnification, are these little vacuoles that mostly seem to be confined to the umbrella cell layer. So the vacuolation in the umbrella cell layer, and the umbrella cell layer itself is quite prominent, as you can see. So that's another feature that we note. And then as you go a little bit closer, the next thing that we want to observe in papillary lesions is the architecture itself, architecture of the urothelial cells. So what do we mean by architecture of the urothelial cells? We are talking about polarity here. So if you can see this particular area, so you can clearly notice that most of these, or almost all of these urothelial cells have this elongated nuclei, and all the elongated nuclei are perpendicular to the basement membrane and also perpendicular to the surface. They all grow in this direction. And if you look around, in every single place, except for the areas where you have some tangential sectioning, the polarity is maintained. They all more or less seem to have the same polarity, oriented perpendicularly to the basement membrane and perpendicularly to the surface umbrella cells and to the surface itself. So that's another feature we notice all around. And then the next thing that we need to identify is the cytologic atypia. So if you go closer, you will see that all these nuclei have very nice regular nuclear borders. They're all like oval, and they don't have pleomorphism. They're all more or less similar in size and shape. And the chromatin is somewhat, I wouldn't call it hyperchromatic. It's somewhat pale in color, and I don't see distinct nucleoli. So you could say the nuclei are a little bit enlarged compared to the normal, but in general, they have this uniformity about them. They have this monotony, and they have this blandness about them. Okay, so once you have noted that, you look around to see if you find any mitotic activity or any apoptotic debris. By apoptotic debris, we mean the karyorectic debris that we get when nuclei start dying off. They start breaking into little pieces, and we get these little dots in the cytoplasm of the cells. We don't see those here. What we see as little dots here are actually some lymphocytes infiltrating into the urothelium itself. So overall, we see these delicate papillary structures without coalescence, having regular polarity of the nuclei, and having a very bland cytology in clear papillary, exophytic papillary formations. And we also have this vacuolation of the umbrella cells. So this tumor will best fit in the category, or I would even say is diagnostic of this neoplasm in the bladder that we call as a papilloma. So this will not fall into the carcinoma category. This will be a benign neoplasm called as a papilloma. So genomically, if you look at papillomas, they usually do have some mutations. These are present in the HRAS or KRAS genes. But more important than that is the fact that papillomas don't show TERT mutations or FGFR3 or other mutations that you would find in papillary urothelial carcinomas, be it low grade or high grade. Bladder, most common mutation, the truncal mutations in the bladder are found in the TERT gene, which you don't see in papillomas. Instead, you see HRAS and KRAS mutation, which are somewhat uncommon in low-grade urothelial and even in high-grade urothelial carcinomas. So first case is a papilloma, completely benign lesion. These tend to occur, as you can see, in somewhat younger patients compared to patients with urothelial carcinoma itself. Okay, so we can go on to case 2 now. So in case 2, we note that the patient is a 50-year-old male. And also significant in the history is the fact that the urologist says it's a dome-shaped mass. So he or she does not say it's a papillary or exophytic mass. They say it's a dome-shaped mass, meaning the top surface of the lesion is smooth and it's not elevated into papillary structures. So we can appreciate that microscopically as well. So if you look at some of these regions here, you can see the surface urothelium is quite flat. And then there is a proliferation which arises from the surface urothelium right here and everywhere else too, which seems to grow into the lamina propria. Right, so that is a pattern that we see all around as we look at it. So here again, you see a surface urothelium that is quite flat, and all of the growth, which is actually is coming from the surface, is all going downwards. So again, here surface urothelium which is thickened, and a growth which is growing downwards. So in some areas, if you look around, you will see there might be a semblance of exophytic projections like this over here. So that does happen from time to time in these lesions. You can see rare exophytic papillary structures. That's because when the specimen is taken out, some of the surface tends to come apart and some papillae just plop out. So you can see that. So you're allowed to have a few exophytic papillary structures in this particular lesion, but the vast majority of the lesion should be growing inwards in an inverted growth pattern. So what are the other features in this lesion other than the inverted growth pattern that we can identify on a low power? So when I go back perhaps to this particular fragment, I notice that there are multiple nests in here, and almost all of them are relatively small, and they are packed back to back against each other. And if you look at this particular fragment, you will see that they have this distinct, almost like the nests fit into each other, like a jigsaw puzzle, pattern. Okay, so this pattern is relevant to this particular case. And once we go closer, we can see that all of these nests in the lamina propria, as I mentioned, are coming from the surface. So you can actually appreciate the surface moving in or invaginating. So it's basically bending in like this. So when it bends in, it takes the top surface, the umbrella cell layer in the center, and then you get the peripheral or basal cell layer towards the periphery of the nest. So you can see the same pattern going in, like the umbrella cell layer is going in and it's in the center, and the peripheral basal cell layer is in the periphery, right? So if you look at some of the nests in the center, you will notice the same pattern. So periphery is somewhat palisaded, it's darker, and it's a basal cell layer. The central area is the umbrella cell. You can even see the vacuolations and somewhat paler cytoplasm. So this pattern is called as the central streaming pattern. So you can see that all these umbrella cells, typically, as you know, are situated perpendicular to the other layers of the urothelium. So you will get that central streaming inside that's perpendicular to the basal cell layer, which is palisading in the periphery. So again, you can see all the changes that you typically see in the umbrella cell area in the center of the lesion. So recognizing this pattern is very important to correctly diagnose these lesions. And the fact that on a low power, you see a jigsaw puzzle pattern of small nests. Okay, so then we go on to look at the cytology here. So cytology we can see is quite monotonous. There is no pleomorphism. The nuclei are pale, maybe a little bit enlarged, but very pale, and they have these tiny nucleoli in them. And the polarity, as far as the basal cells are concerned, is more or less maintained. And you can see some disorder here. That's because there is this central streaming, which is mixing in with the basal cells that are in the periphery, right? So overall, it has a maintained polarity. And then after that, we look for other ancillary features such as apoptotic figures or mitotic figures, and we do not see any of that. And as I mentioned before, all these nests are smaller in size, and they're of normal urothelial thickness if you look at the basal cell layer and the umbrella cell layer. And they do not have this expansile nesting growth pattern. And more importantly, they do not have features of invasion, meaning all these nests are nice and round, and they have smooth surfaces on the outside. And the stroma itself is not reactive. So there are no features of invasion where you would see a jagged infiltration in the stroma with the presence of myxoid stromal change, like a desmoplastic stromal reaction. So you don't see that anywhere. So this is a classic presentation of what is known as an inverted urothelial papilloma. And it's also very important to know that urothelial carcinomas, such as a low-grade or high-grade carcinoma, can also grow in an inverted growth pattern, but they do not show other features we see in an inverted papilloma that I just discussed, like the jigsaw puzzle pattern or the central streaming and the peripheral palisading and the lack of mitotic figures and apoptotic debris and the cytologic blandness. So genomically speaking, these inverted papillomas show very similar changes to what we see in the everted papilloma, which we saw in case 1, or the exophytic papilloma, meaning that they also have these HRAS and KRAS mutations, and they do not carry the TERT mutations that we see in carcinoma. So if at all there is a question on a small biopsy whether this could represent an inverted urothelial carcinoma, low grade or high grade, you can genomically test them to see if TERT mutations are present. But other than that, immunohistochemically, they show similar features as of all other papillary lesions, including carcinomas. All right. So then with that, we can go into case 3. So this particular case, you can see, is an older patient. And this time, this patient has multiple papillary tumors, one of which we see here. So compared to the previous case, or in contrast to the previous case, and similar to the first case, here we see mostly an exophytic growth pattern. So all these papillae are growing upwards into the lumen, and you can see clear-cut papillary structures with a fibrovascular core in the center, right? So it is a rather small lesion, but you can definitely see these exophytic papillae and no endophytic or very little endophytic growth pattern inside. So what is the difference between this case and case number 1? So if you notice, even from a low power, you can appreciate that the thickness of the urothelium, right? The thickness of the urothelium is much higher than what we saw in case 1. So we can pull it up for comparison here. So you could see the thickness here is pretty much as that of the normal urothelium, unless you're looking at tangential cuts. But in this particular case, you can see the thickness is much higher, right? And then the other feature we notice is in many areas, these thickened papillary structures seem to be confluent with each other, like they are merging with each other. So you can see this confluent pattern in which the papillae are not separate, like we see in the papilloma. So again, this merging confluent pattern that we notice. So these are the two important things that we notice from a low power: the outward papillary growth, the thickened epithelium, and also the merging or the confluent pattern of growth. Okay, so then we try to go into higher power and look for our other usual details, the architecture and the cytology, right? So the architecture. So what do we see here? So we can clearly notice that these nuclei are located all perpendicular to the basal layer and perpendicular to the superficial umbrella cell layer, and they're all pointing in the same direction. So this is actually a very polarized growth pattern, right? So there is a uniform polarity throughout. So anywhere you look in the lesion, so you get that uniform polarity. The other feature that I notice here is the fact that you could see here the umbrella cells are retained on the surface. So you can see the umbrella cell nuclei are oriented a little bit like parallel to the surface and perpendicular to the underlying urothelium. And they also have these little vacuolations. We can try to look at another area as well. We can see these features better here. So you can see the umbrella cells are intact on the surface of this lesion. They do have these little vacuolations, but compared to what we saw in case 1, the vacuolations are not prominent. So you can see how prominent these vacuolations are, right? So that is unlike what we see in a papilloma. And then we started talking about the polarity of the cells. So you have to note that when we talk about polarity, you have to take into consideration the orientation of the fragments. So you have to study polarity only in areas where you know the fragments are oriented appropriately, right? So for example, if you look at some areas that are tangentially cut, you could get a sense that, okay, maybe I don't really see nicely polarized epithelium over here. So here, in fact, you can see there is some haphazard arrangement of the nuclei. So you should not mistake this for loss of polarity, because if you go into a lower power or lower magnification, we'll notice that this is a tangentially cut area, right? So this should not be taken into consideration. In fact, so in those cases, you have to look at well-oriented areas and confirm that the polarity is indeed maintained. Right. On this point, I also want to point out to you the fact that the urothelial lesions, especially the low-grade carcinomas, have something called the urothelial eddies. So you can see an example here. So there is a little swirling, all these little swirls of urothelial cells, right? So there's another area too I can try and point out to you. Can't find it right now, but you get these little swirls. So what happens when you see these swirls is that you could be fooled into thinking there is a loss of polarity. So in these areas where you get these little swirls, we call them urothelial eddies. And these eddies are normal phenomenon in urothelial cancer, right? So this should not make you think there is loss of polarity in these areas. So that's one caveat that we have to remember. Okay, then we start looking at the cytology itself, and we try to understand if the cytology is bland appearing, low grade appearing, or not. So you can see that almost all these nuclei are monomorphic, and they have this regular nuclear membrane. And there are maybe some enlargement of the nuclei, maybe some small nucleoli, but overall you get a sense of monotonous proliferation, right? What is different from the papilloma that we saw first up is the fact that many of these nuclei, so you can, any of the fragment that you go into, you can see many of the nuclei have a very dark or hyperchromatic chromatin. So this hyperchromatism starts happening when the lesions progress into low-grade carcinoma, and you will see more and more of this when they progress to high-grade carcinoma. So the presence of this hyperchromatism in many of the nuclei is another indication that this is actually a carcinoma. The other fact beyond that we must notice is, like, all this are apoptotic figures. Like, these are single cell death happening because of the rapidity of the proliferation in this lesion. And you can see all these little dots means there's a lot of apoptosis happening. So typically in papillomas, you do not see that. Okay, so try and observe for the presence of apoptosis. So we can see if we can find it in another area as well. So in this particular so maybe a little bit over here, and maybe a few apoptotic cells over here. And in this field, you can even try and identify a mitotic figure. So that probably is a mitotic figure. So you can see rare mitotic figures, especially confined to the basal layer, not usually in the middle or top layers of the urothelium. So the presence of apoptotic figures and rare mitotic figures is also compatible with a diagnosis of what we are seeing here. We see more apoptotic figures here of a low-grade urothelial carcinoma. So this is a classic appearance of low-grade urothelial carcinoma, low-grade non-invasive papillary urothelial carcinoma. And the features that we just discussed are the ones that help you distinguish these lesions from papilloma. Right, the confluent papillary growth, the exophytic nature, the increased thickness of the urothelium, and the monotony of the cells, the hyperchromasia that you find. And if you hunt around, you find apoptotic debris, and you also find rare mitotic figures. So these are features of low-grade urothelial carcinoma. We will talk about how to contrast it with high-grade urothelial carcinoma in the next 2 slides. But before that, I want to address this entity known as PUNLUMP. PUNLMP. So that is an acronym that stands for Papillary Urothelial Neoplasia of low malignant potential. So what is this PUNLUMP? So PUNLUMP is, first of all, a diagnosis that I rarely use. So you would see in most practices, PUNLUMP is a diagnosis that is used maybe once a year or twice a year. So what is this lesion and why was it introduced? So to me, conceptually, PUNLUMP is nothing but a very, very early stage of low-grade urothelial carcinoma. So in a PUNLUMP lesion, you should find features that are slightly higher than what you would find in a papilloma. Like, for example, slightly increased confluence of the papillae, slightly increased thickness of the urothelium, and slight enlargement of the nuclei with very rare hyperchromatic nuclei, and almost no mitotic figures or apoptotic debris. So this type of lesion can be called as a PUNLUMP, especially when we find these papillary growths in younger patients in whom you don't want to give a diagnosis of carcinoma because these tumors typically behave very well. So you don't want to label them with a diagnosis of carcinoma. So that is the case when the diagnosis of PUNLUMP or papillary urothelial neoplasm of low malignant potential is identified. So genomically speaking, we discussed earlier that the papillomas, the inverted and everted papillomas, they carry KRAS, HRAS mutations, but they do not carry TERT mutations like what you find in carcinomas. So this lesion, which is a low-grade papillary urothelial carcinoma non-invasive, will carry TERT and or FGFR3 mutations. And similarly, if you look at cases of PUNLUMP, most of them, they carry the TERT mutations. Which implies to you that they are actually a very low version or lower end of the spectrum of papillary urothelial carcinoma rather than belonging to the papilloma category. Okay, I hope that's clear. So let's move on to case 4. So this is a older gentleman who actually presents with macroscopic hematuria this time. So from a low power, we start to appreciate the features that we were looking out for in the previous cases. So we do find that there is an exophytic papillary growth pattern, especially in this fragment. And in other fragments, like this one, for example, it looks like there is also an endophytic component. And we can actually see that endophytic component here and also here. And there's something endophytic going on in this fragment as well. So again, in contrast to the papilloma that we saw first, and in comparison to the low-grade urothelial carcinoma we saw in the last case, we could see that these papillae are not distinct, and they are clearly much more thickened than what we saw in a papilloma, right? And there is also considerable confluence of the papillae. So you can see that the papillae here are very, very thick because there are multiple papillations here that are coalescing with each other. So which gives rise to the thickened appearance. And in some places, it is so confluent and coalescent that the entire thing almost appears as if it's a solid proliferation, right? So very thickened papillations with both an endophytic and exophytic growth pattern. So we appreciate all those in a low power, and then we go into higher power to see what is happening in this lesion. Right, so let's go in somewhere over here. Then we go through the algorithmic process of trying to notice whether there is polarity loss or not. So in contrast to the previous cases that we saw, you can clearly see here that there is a definite sense of disorder of these cells. They are all growing in different directions, a very haphazard arrangement to the cells over here, no polarity, no perpendicular or parallel structures that we see over here. Every single nuclei is pointing in a different direction. So that loss of polarity is clearly seen in this fragment over here, right? And then the other feature that we must notice after polarity is the cytology. So the cytology is clearly high grade here. So you can see that there is considerable pleomorphism, many hyperchromatic nuclei, and then there is chromatin irregularity, nuclear membrane irregularity as well. And then you also start seeing these mitotic figures. So it's not very difficult to identify mitotic figures in this case. So if you go to any field, so you can always find some mitotic figures. So it's easy to recognize mitotic activity and also apoptotic activity. In this case, you can see plenty of it here, right? So you keep going around. So any field you go, you will always have an opportunity to come across mitotic figures. Many times you can see atypical mitotic figures. So this is clearly a papillary urothelial carcinoma that is showing high-grade features. So high-grade papillary urothelial carcinoma, right? So after you have made the diagnosis, the next thing to look for in these lesions is to see whether there is any invasion or not. So sometimes when you see areas like this, where there is an endophytic or ingrowth of the papillae into the lamina propria, these could be mistaken for invasion by beginners. But if you notice that these areas, right, so the nests are actually very smooth. The outer surface of the nests are very smooth, and oftentimes you will see these little capillary structures around the periphery of the nest. Okay, so these features make it a non-invasive growth pattern. You get this appearance of these nests being present in the lamina propria, either because they are pushing into it without invading, or because it is a tangential section. Okay, when you have an actual invasion of the lamina propria, which is very important to look for in these high-grade lesions specifically, so you would see other features, such as you find in this fragment, right? So here you find very irregular, jagged nests of urothelium that are invading into the lamina propria. And in addition to that, you also find that the stroma itself, the lamina propria around, is showing some changes. There is some myxoid change here, some loosening of the stroma, and perhaps some associated inflammatory infiltrate. So this is what you should be seeing in an invasive growth pattern in urothelial carcinoma. So now we have made the diagnosis of high-grade papillary urothelial carcinoma with invasion into the stroma. So the next thing to do is to actually qualify that invasion. So we need to know how far into the bladder wall this tumor is invading. And as most of you know, the presence of urothelial carcinoma invading into the muscular propria will be an indication for cystectomy. So this is a very important diagnosis to make in these tumors once you identify invasion. So let's see what we can do about this case. So here we follow the invasion, and we can see there are several invasive nests over here, and there's also invasion over here when where there are these irregular jagged nests with the stromal reaction. And this is an area where we can see some larger muscle bundles. So perhaps this is actually invading into the muscularis propria. But you can see what might be a little bit of a difficulty for many people in this type of lesions, because we have something called as the muscularis mucosa in the lamina propria of the bladder, which is quite superficial. As you can see here, the tumor is clearly infiltrating into the muscularis mucosa, and sometimes the muscularis mucosa can get thickened, and it is an irregular layer. So you can follow it here, and it's quite close to this layer as well. So you might come across a difficult situation in which you're not able to say whether the more deeper layers are actually an extension of the muscularis mucosa or the beginning of the muscularis propria. Okay, so especially in TURBT or transurethral resection specimens where the orientation is not good and you have this cautery-related changes, it might be very difficult to say. So what do we do in this situation? So whether or not you're confident about muscularis propria invasion, it is imperative to qualify the depth of the lamina propria invasion. Okay, so what do I mean by that? So we typically define lamina propria as superficial and deep. And the anatomical landmarks that are used to make this definition is actually this muscularis mucosa and also the thick-walled blood vessels that we find in the lamina propria. So if the tumor, once you know that the tumor is invading into the muscularis mucosa, or at the level of these larger blood vessels, you can see a larger blood vessel here as well. So you should call it deep lamina propria invasion. So this tumor, for sure, 100% of us can say is invading the deep lamina propria, even if 100% of us don't agree whether this is muscularis propria or not. So this diagnosis should be made as high-grade papillary urothelial carcinoma, invasive, and the extent of invasion should be qualified as invading at least into the deep lamina propria. So this information is important to the urologist, and we should avoid just saying the tumor invades into the lamina propria without further qualifying it. Okay, so this is what I wanted to talk about in this particular case. So let's move on to the next case, which is case 5 over here. A 65-year-old female who has a recurrent bladder tumor. So again, we go through the motions. We see that this is an exophytic papillary lesion, right? Exophytic papillary lesion in most places. Maybe there are fragments where there is somewhat of an endophytic growth pattern. And we can also see that there is clearly some confluent growth pattern here, right? So confluent exophytic papillary neoplasm, which tells us from low power, this is a papillary urothelial carcinoma. Okay, so as you know, the next step is to grade this carcinoma. So we're going to see if the cytology and architecture are that of a low grade or a high grade urothelial carcinoma. So if you look into this particular fragment from this magnification, you notice that there seems to be some retained polarity, right? So most of these nuclei seem to be perpendicular to the basement membrane. They're all facing in the same direction in most of these invaginating fragments here. Okay, and then if you go closer, you will see that the cytology is also not so bad. So it looks quite bland, and almost all the nuclei are of similar size and shape. I don't see pleomorphism, and I see regular nuclear borders, and I see only maybe some enlargement of the nuclei with tiny nucleoli, right? So overall, it seems to have a sort of a low-grade appearance to it, at least from a lower and medium magnification, and you even start seeing some type of central steaming-like thing. So we'll come to that later, but what catches my eye as I go into higher power in this particular lesion is that I can start spotting mitotic activity without much difficulty. So here's a mitotic figure, here's another mitotic figure, and then I see some apoptotic debris, another mitotic figure, another mitosis, and you might notice it's actually quite high up in the urothelium, not just confined to the basement membrane, right? So you go from field to field, you know, you see several apoptotic figures, and you easily come across mitotic activity. There's one here, one here. So this seems to be an extremely proliferative lesion, despite the somewhat bland appearing cytology. So even though officially we don't take mitotic activity into consideration while making the diagnosis of urothelial carcinomas, one should always be aware of or exercise caution when we see such increased or such a high extent of mitotic activity in what looks like a low-grade papillary urothelial carcinoma, right? So what do you do in this situation? So what you do is try and look for other areas in this tumor, because this increase in mitotic activity, the tumor is trying to tell you that maybe it has gained more mutations, maybe it is progressing towards a higher grade. So maybe you will find other fragments in the tumor which show areas that that perhaps are a little bit more convincing for a high-grade carcinoma. So let's see if we can find anything like that in this tumor. So this is another fragment here. There is some, many of the cells are showing hyperchromasia. There is some subtle increase in nuclear shape and size. And then you come to this area where again, you see a lot of mitotic activity anywhere you look. And you can also start seeing these very enlarged nuclei, right? Clearly, high-grade atypia here. There is nuclear pleomorphism, hyperchromasia, as well as the mitotic activity. So we now get more clues that probably this is a lesion that may not be low grade, right? And then you come across another fragment here where you can clearly see that there is a loss of polarity. So there is a sense of haphazard architectural arrangement here, which we did not see in the first fragment that we were looking at. And you can see the amount of apoptotic debris that we see in these areas. So you got everything you need for a high-grade carcinoma in this case, despite the seemingly low-grade appearance in some areas, right? So you got the loss of polarity, you got the increased mitotic activity, you got the nuclear atypia. So this is a case where a low-grade carcinoma is progressing into a high-grade urothelial carcinoma. This is a known phenomenon in urothelial cancers. So urothelial cancers typically start with, as we spoke about earlier, TERT mutations and FGFR3 mutations. And then when they progress to a higher grade, they gain P53 mutations, RB1 mutations, and plenty of other mutations down the line. So they can, some areas in the tumor can show a low-grade clone, where other areas that have acquired more mutations can show a higher grade clone, okay? So what this means is every diagnosis of low-grade urothelial carcinoma, you have to be very careful in examining the whole specimen, especially when you see a relative increase in mitotic activity or apoptotic debris that you're not expected to see in a low-grade carcinoma, right? So whenever you get that little doubt, always be careful and look around the entire specimen, right? So to see if there are any high-grade changes. So here you can have the question, so how much of this high-grade area should I see before I actually make a diagnosis of high-grade urothelial carcinoma arising in the background of low-grade tumor? So the answer to that question is a little bit nebulous. There are various studies showing various cutoff points, but in general, the consensus in the practice is that you should see at least 10% of the tumor showing these high-grade areas for you to call it as a high-grade urothelial carcinoma. So 10% is the typical number that we use. And then coming to the issue of invasion. So once you have made the diagnosis of high-grade urothelial carcinoma, you start looking for invasion. So we come back to this fragment over here, where we decided this was an inverted growth pattern because there was no stromal reaction and the borders are pretty smooth. So this is not invasion, right? But what I wanted to point out here is, if you remember the inverted papilloma that we discussed in case 2, so I can bring it up here. So you can see, in contrast to the growth pattern here, the jigsaw puzzle pattern in the inverted papilloma contains very much smaller nests, and they fit into each other nicely compared to this where the nests are quite expanded, right? So whenever you see an expansile growth pattern, expansile inverted growth pattern, so you have to suspect that maybe it is not an inverted papilloma. So maybe it is a urothelial carcinoma, either low grade or high grade, which is growing in an inverted growth pattern. And then you go closer to appreciate details that we spoke about earlier, such as nuclear atypia, loss of polarity, mitotic activity, apoptotic figures, and so on and so forth, to make correct diagnosis in this particular case. So this is a high-grade urothelial carcinoma, non-invasive, arising in the background of low-grade carcinoma. So moving on to case 6, we see that this patient is 50 years old and has irritative voiding symptoms, not hematuria, but actually irritative voiding symptoms. And the patient is also a little bit younger than some of the previous cases that we saw with urothelial carcinoma. Okay, so there are multiple fragments over here, and one of the fragments seems to stand out because it looks much busier than the rest. Okay, so let's look at this fragment first before we go there. So here we could see, we don't really see a definitive papillary growth pattern, but there is a thickening of the urothelium. The nuclei seem a little bit enlarged. There may be some tiny nucleoli, but I don't really see a significant loss of polarity or other activities such as hyperchromasia, apoptotic figures, or mitotic figures. So let's move on to the much more interesting fragment right here. So here we can see that there is clearly a papillary proliferation, right? So there are these elongated exophytic papillary structures. And in some areas, there also seems to be a little bit of a confluent growth pattern when the papillae seem to be merging with each other. So let's take a closer look here. So when we look at this closer, we can easily identify that all these nuclei are more or less monotonous in appearance. And again, they have regular nuclear borders. They are maybe slightly enlarged, and their polarity is maintained. They're all perpendicularly maintained, perpendicularly oriented to the basement membrane. Maybe there is a mitotic activity over here. It's a little bit iffy. So let's look at some other areas. So in some other areas like this, for example, perhaps there is a little bit more of a nuclear enlargement. Perhaps there is a mitotic activity over here. Perhaps there is a little bit of increased atypia and some loss of polarity. Okay, so there seems to be some conflicting findings over here. But the elephant in the room here is the inflammation. It's staring at you right in the face. You can see that most of the areas in this lesion are packed with neutrophils. So the lamina propria itself is heavily inflamed. You can see that there are plenty of lymphocytes here and plenty of plasma cells infiltrating the lamina propria. And not only that, if you go into the surface urothelium itself, there are numerous neutrophils infiltrating the surface all over the place. And interestingly, you also see some mucinous metaplasia in the urothelium. These little mucoid globules are seen in the urothelium. In other places, you see almost what looks like a neutrophilic abscess in the epithelial layer itself. So whenever you see such an extent of inflammation, in order to make a diagnosis of urothelial carcinoma in this background, the atypia, the extent of atypia has to be above and beyond what can be due to reactive changes from the inflammation itself. So what I mean to say is your threshold for diagnosing carcinoma in the background of inflammation, especially inflammation which is present in the urothelium itself, should be much, much higher, right? So I'm not saying that you can never get carcinoma in the background of inflammation. You can get it, but to make the diagnosis, you need to have much more atypia than what we see over here, and you need to have much more loss of polarity than what we see in this particular case. So this happens to be a case of what we call as papillary cystitis. It is not neoplastic. It has no mutations. It is a case of papillary cystitis where the papillary growth is a reactive change in response to the inflammation that this patient is experiencing. Another feature that helps us differentiate papillary cystitis from papillary carcinoma, even on a low power, is the fact that if you look at some of these papillae in papillary cystitis, they have a very bulbous core, right? So this is a very thickened core, again, a thickened core, and usually this bulbous core is due to edema and inflammation filling the core. So these features are somewhat unusual in papillary urothelial carcinoma. So this is a case of papillary cystitis. Okay, so case number 7. And here we start switching gears a little bit. So this is a older patient, 70-year-old male patient who presented with microscopic hematuria. So there are several interesting fragments in this particular case. So maybe let's focus on these middle fragments first. So again, from a low power, we can notice that the urothelium does not look normal, right? So it has these papillary projections, and some of these papillae are confluent. And if we go into a higher magnifications on this papillae, perhaps somewhere here, we can see that there is some nuclear enlargement, maybe a little bit of disorder, but overall, I don't see sufficient pleomorphism. So this looks like maybe suspicious for a low-grade papillary urothelial carcinoma, perhaps in an early stage. The other interesting part about this case is there seems to be a very pronounced invagination of this surface into the stroma over here. I say invagination because I don't see evidence of invasion, right? And again, we see an invagination, or maybe it's a diverticulum with this papillary growth with confluence in this area. The other interesting feature here is the fact that there are some little nests in the lamina propria just beneath the epithelium that look very suspiciously like von Braun's nest, which is essentially invagination of the urothelium that then gets cut off from the surface. So von Braun's nest-like proliferations in the lamina propria. So if you look at this fragment over here, it has similar features. You see a surface papillary proliferation, which looks mostly low grade, and this diverticulum-like invaginating pattern over here. And then let's look at a couple more fragments. The one at the bottom over here. So again, you see what perhaps it's a very early low-grade urothelial carcinoma, and then these von Braun nest-like proliferation that seem to be confined to the lamina propria here. So, so far, this case is rather uninteresting. You see a low-grade, non-invasive type papillary urothelial carcinoma, perhaps with some von Braun's nest. But here, there is a very, very interesting fragment. So what's going on in this particular fragment? So in this fragment, we don't see much of a papillary proliferation on the surface, perhaps because it's cauterized, but beneath the surface, we see these several little nests of urothelial proliferation, some of which seem to be a little bit confluent. If you look into these nests, you will see that the urothelial atypia is very, very low. It's not pronounced at all, and it looks rather cytologically bland and monotonous. Maybe some increase in nuclear size, maybe some small nucleoli. This is what we expect in von Braun nest. So this is still okay for von Braun nest at this magnification. However, if you pull back, you will notice something very strange. So you will see that these are muscularis propria, and you will see that these von Braun, so-called von Braun-like nests, are actually invading or present deep inside the muscularis propria. So this is an absolutely not acceptable definition for von Braun's nest. You should never, ever see von Braun's nest inside the muscularis propria. So this cannot be von Braun's nest once you see this finding. So what this actually represents is a nested pattern of urothelial carcinoma. Highly deceptive pattern, especially if you get a superficial biopsy. So if we go back to this prior fragment over here, and let's say this is all we got, there is no way we can make a diagnosis of nested urothelial carcinoma with confidence when we don't see muscularis propria or the tumor going into the muscularis propria. So you can see how difficult this can be in small biopsies, and this case could easily be called as a early non-invasive low-grade papillary urothelial carcinoma, whereas this case is actually a high-grade urothelial carcinoma with a nested pattern, right? Because we see invasion of these nests into the muscularis propria. So nested urothelial carcinoma, despite its bland cytologic appearance, is a high-grade tumor. It behaves similar to invasive high-grade urothelial carcinoma, and this diagnosis is a very critical one to make. All right, so let's go to case 8 now, which is related to case 7. It's again very interesting. This patient then, because of this diagnosis, underwent cystectomy, and then we see some ureteric margins in the cystectomy case. Right. So here, the ureteric margin clearly, even at low power, shows some very interesting features. So the surface urothelium itself seems rather bland and well behaved. So we're not gonna make a diagnosis of urothelial carcinoma here. But as we look at the lamina propria, there is a proliferation, or it's a very remarkable proliferation of these nests of urothelium inside the lamina propria. And some of them look a little bit irregular, a little bit jagged and confluent maybe. So since we know that this patient had nested variant of urothelial carcinoma, we get very concerned when we see a proliferation like this, especially at the margin. So the question obviously now is whether to call this margin positive for invasive carcinoma or not. So again, in this other fragment, we see a similar proliferation of urothelium in the lamina propria, right? But I want to point out a couple of things here. It's just very important to not making a diagnosis of nested urothelial carcinoma at the margin in this case. One, you notice it at low power, right? In a low power, you will see that all these nests, despite the exuberance of the proliferation, are confined to the lamina propria. None of them go deep into the muscularis propria. And similar findings here, you will find all these nests, some of them, even if they get a little bit close, they never enter the muscularis propria plane itself. They're all confined to the lamina propria. So that is point number 1, that it may not represent nested variant of urothelial carcinoma. Point number 2 is the knowledge that the ureter, especially the renal pelvis region, will have a very prominent Von-Bruns nest. Compared to the bladder, the ureter and the renal pelvis have very prominent Von-Bruns nest that you might see in several cases. So these two factors tell you that this is actually not nested variant of urothelial carcinoma, but is Von-Bruns nest in the ureter. So for comparison, you can pull up the previous case. So you can look at the cytology very carefully over here. Cytology looks very similar to the urothelium on top, and it's rather bland, and the nuclei are small, nicely rounded, right? So we pull up the other case, the nested variant, right here, and we go to the fragment of interest. So you will notice that even though the cytology is bland, I can put you at the same magnification here. Let's see, maybe a 10x. And we can put the same magnification here at 10x. So you can see that these nuclei are perhaps somewhat larger, or perhaps showing a little bit more pleomorphism, right? And a little bit more atypia compared to the case that we called as Von-Bruns nest. So there is a very subtle difference in the size, in the cytology of these nuclei. I emphasize the word subtle because oftentimes without context, it might be very difficult to appreciate. That's why these cases are so difficult to diagnose, especially if you get a superficial biopsy. So then the next question is, are there any ancillary tests that can help us differentiate Von-Bruns nest from a suspected nested variant of urothelial carcinoma? The answer is unfortunately no in most cases. However, I will point out that some authors have shown that nested variant of urothelial carcinoma is often positive for PAX8, whereas the cells in the Von-Bruns nest are not positive for PAX8. Here, there is another caveat, because in the upper tract, the urothelium tends to be naturally PAX8 positive. So you have to be very careful in this situation when you're applying PAX8 to make this differentiation, right? And the other thing that you can do is, if you have the facilities and you're able to micro dissect out these areas, you can actually check them for mutations. As I mentioned before, the urothelial carcinomas often start with TERT mutations, and the nested variant also has that. So if these clusters show TERT mutations or TERT promoter mutations, you know it is carcinoma, and if they don't, you know it's von Brunn's nest. Okay, so very interesting case, and we can move on to the next one here. Just case 9. This is an older male with a bladder mass. And you can see here clearly there is a papillary tumor. It is so fragmented that it's maybe harder to appreciate the papillary areas. But as you go closer, you can see some papillations here, and you can see some confluent papillations here, and maybe more papillations here that are all broken up due to the nature of the specimen itself, right? So then we do our next step, we go closer and we see, look for loss of polarity and cytologic atypia. And here, so we can see without any doubt that there is a significant loss of polarity in these cell layers. And then there is also a significant cytologic atypia, right? And we also find other features that we usually look for. We find mitotic activity, we find several apoptotic cells. So this is clearly a high-grade papillary urothelial carcinoma, right? So once we make a diagnosis of high-grade urothelial carcinoma, of course, we know the next step is to see whether or not there is invasion. And we come across some fragments where we clearly see that there is invasion, jaggedness into the lamina propria. So this is a high-grade invasive papillary urothelial carcinoma. So we've made the diagnosis. So is it time to move on to the next case? Well, so here I would say that it's not, because there are other things that we need to do in high-grade urothelial carcinomas that I did not mention before, that we need to add to the diagnosis. So what are those things? So that is to look for divergent differentiation, or to look for any subtypes of urothelial carcinoma that might have a prognostic or a therapeutic significance, right? So what do we mean by divergent differentiation? It is differentiation into architectural morphologic features that are not your regular urothelial carcinoma. For example, here you can see some gland-like proliferations in the mucosa here. So little gland-like structures, and it's even better seen here. So this looks pretty much like an adenocarcinoma that you would see in other organ systems. So this is divergent differentiation in the form of adenocarcinomatous differentiation. Right. So many urothelial carcinomas, especially the high-grade ones, can show divergent differentiation. Now, the key thing to remember here is once you see divergent differentiation or one type of divergent differentiation, you should not stop. You should also look for other divergent differentiation types, because urothelial carcinoma often undergoes, it's an extremely plastic type of epithelium. It can undergo several types of divergent differentiation, and some of them have a critical prognostic significance. This case, for example, if you look at this particular fragment over here and you go closer, you will see that it starts showing features of a small cell neuroendocrine carcinoma, right? So you see a very high cellularity, you see a monotonous growth, and you see lack of nucleoli, and perhaps you see some nuclear molding and maybe some granular chromatin, as well as numerous mitotic figures, right? So this is an area that was strongly positive for synaptophysin and chromogranin, which supports the diagnosis of small cell neuroendocrine differentiation. So this is a very important diagnosis to make, because as you know, prognostically, these tumors are much worse, and they may also be treated differently if there is a substantial component of this small cell neuroendocrine differentiation. So this is a high-grade urothelial carcinoma with divergent differentiation in the form of adenocarcinoma and small cell neuroendocrine carcinoma. Okay, so with that, let's move to case 10, which is a 77-year-old female with a bladder mass. So we are on the topic of subtypes and divergent differentiation. So let's look at a little bit more of that. So again, we see that this is a papillary urothelial carcinoma, exophytic papillae with a confluent growth pattern, perhaps also some inverted growth pattern over here. right? And then we look closer, we see that there is sufficient loss of polarity, there are plenty of mitotic figures and cytologic atypia, right? So we know for sure that this is a high-grade papillary urothelial carcinoma, non-invasive so far, but as we keep going through other fragments, we see some peculiar clefting of the urothelium in these areas. And if you can imagine, you will also maybe see some little micropapillae-like structures on the surface. And it separates out a little bit better over here. So you can see this little micropapillary structure on the surface, which is somewhat of an interesting finding here. And then as you move on, you see some more remarkable findings in this case. Here, it seems like there is a clearly invasive component in this urothelial carcinoma. And if you look closer in this invasive component, you will see multiple micropapillary structures, little finger-like projections without papillary cores. So that's a definition of a micropapillary structure. And to call something as a micropapillary subtype of urothelial carcinoma, you should always have an empty space in which you have numerous multiple micropapillary structures. So this is the definition of micropapillary urothelial carcinoma, right? This definition is important because, like, for example, if you see this little island over here, you can oftentimes have invasive urothelial carcinoma with retraction artifact. So those should not be mistaken for micropapillary urothelial carcinoma. That is why it is emphasized that to make a diagnosis of micropapillary urothelial carcinoma, you need to have an empty space in which you have multiple micropapillary structures, okay? So that is a very useful and highly sensitive or specific feature of diagnosis. And then the other feature that is also highly specific for diagnosis in micropapillary urothelial carcinoma are these so-called epithelial ring forms. So you can see some epithelial cells with the cytoplasmic vacuolation with multiple septations in some cases. So these are called epithelial ring forms. So let's see if we can find better ones for demonstrating the epithelial ring forms. Maybe here. Yeah, so you can see multiple cells here with the cytoplasmic vacuolation. So these are the ring forms, and you can almost see a signet ring-like structure over here. So the presence of these epithelial ring forms and multiple micropapillary structures in a single space, so that makes for the definition of micropapillary urothelial carcinoma. And we all know that this is a very important diagnosis to make because these are highly aggressive tumors, and micropapillary urothelial carcinoma can often metastasize very frequently and rapidly into distant locations, including the lymph nodes and other visceral organs. So even if there is no muscularis propria invasion, even if you see only lamina propria invasion, like what you see over here, some of these patients will be eligible for cystectomy, right? Unlike other variants or subtypes of urothelial carcinoma. So that's why it's important to make this diagnosis. And the final point here that I will mention is when I started out with this case, I showed you some areas, perhaps here, that showed somewhat of an in situ micropapillary growth pattern, this one. So it is important to recognize that the in situ micropapillary growth pattern itself does not confer a prognostic significance. To call something as a micropapillary variant of urothelial carcinoma, you need to see an invasive component, okay? That's what makes the difference. So with that, let's move to the last case of the day. This is case 11, the 75-year-old male with a bladder mass. So this case is very interesting for several features, for several reasons. We can quickly go through this. So we can see that there is a very solid proliferation of urothelial cells. Maybe there is some population, but it's really hard to see because everything is so packed with cells. It's almost like a solid proliferation here. So if you go into some of the areas in this case, so you might see some unusual papillary structures. but this is not what we typically see in regular urothelial carcinoma, right? And it clearly seems to be invading into the muscle over here. So I see several areas of invasive carcinoma into the muscle. So maybe it's an invasive high-grade urothelial carcinoma. And also here we see invasion into the lamina propria quite clearly, right? So I want to rewind a little bit back to when we started discussing how to make a diagnosis of these urothelial carcinomas and how to go in a stepwise algorithmic fashion. Perhaps the first step that you should include here, especially when you see an invasive carcinoma like this, is to make sure it's actually coming from the bladder, right? So how do we make sure the tumor is actually coming from the bladder? So the foolproof method for making sure the tumor is actually arising in the bladder is to look at the surface urothelium, right? So wherever we can find surface urothelium in these tumors, we have to look at that. So if the surface shows in situ carcinoma, then it is most likely that the invasive carcinoma below also is part of the urothelium. So it's probably urothelial carcinoma. But if the surface is benign, like what we see here, and we can look at some other fragments too. So you can see this fragment, you also get a little bit of the surface urothelium. Again, it's very benign looking, and it looks like most of this cancer growth is underneath, trying to undermine the surface urothelium. So that is a very unusual feature for high-grade invasive urothelial carcinomas, because in a TURBT of this size, you must see at least some areas that show convincing in situ either flat or papillary urothelial carcinoma. The other unusual feature about this particular case is the fact that it has this foamy nature to it, the clearing, the vacuolation, the foamy nature to the cytoplasm, which is somewhat unusual. And then if you look closer at some of these very densely packed fragments, you will see that all these nuclei are actually monotonous. They have very nice round nuclear membranes, and they all seem to have a very uniform, prominent nucleolus. Okay, so this is unusual for urothelial carcinoma because it's one of the carcinomas that is highly aneuploid, meaning that these urothelial carcinomas typically have a higher degree of pleomorphism than we see over here. So this actually happens to be a case of prostatic adenocarcinoma that is invading into the bladder. And these spaces that we see over here are actually glandular spaces that we see perhaps in a pattern 4 prostatic adenocarcinoma, that cribriform pattern 4 of prostatic adenocarcinoma. So this is not even urothelial carcinoma. This is invasive prostatic adenocarcinoma extending into the bladder. So this is a very important point to note in bladder tumors, because bladder tumors, bladder can be invaded by adjacent organs, cancers such as the prostate or the colon or the endometrium in female patients. Not only that, you can also have metastatic cancer in the bladder. We've seen cases of biliary adenocarcinoma in the bladder, several times breast carcinoma in the bladder. That can be very deceptive because both of these, as you know, breast and bladder are GATA3 positive. So you need to have a high index of suspicion, and you also need to have the clinical history, and you always need to look at the surface to see if you can find any dysplastic features of or carcinoma in situ to make the diagnosis. I will also mention here that we've also seen a case of mucosal melanoma in the bladder that was positive for cytokeratin. So you can find some unusual things in the bladder, and you should make sure you make the right diagnosis in those situations. So that's all I have for today. Happy to take any questions or comments if there are any.
So could you briefly also talk about grading and staging of these tumors? Because that's generally like required in the report as well.
So we did speak about grading. We spoke about the neoplasms that are papillomas that are not carcinomas. We spoke about how to diagnose low grade and how to diagnose high grade tumors. I spoke a little bit about the staging when I spoke about the muscularis propria and the muscularis mucosa and the invasive high grade carcinoma.
Yeah.
But I will speak more about staging, especially stage 2 and stage 3 in the next session. So this session, I mostly wanted to cover the spectrum of papillary urothelial carcinomas and its variants.
Yeah,
Thank you.
Well, I'm very excited to look forward to that next session with you, Paari. This has been a very thorough and very helpful discussion of this topic, which is often challenging, the pun lumps and the low grades and so forth. So thank you so much for your time today. There was one question I had, was whether or not that very hypervascular appearance that you had in your low-grade lesion which was not present in the benign papilloma. Is that predictive, or is that a helpful feature? Do you ever find that?
That's an interesting question, Dr. Hassel. That might be a helpful feature for the urologist when they look through these tumors in the cystoscopy. They might find that the higher grade ones are more, they're not as delicate, they're not as translucent, and they appear more erythematous. But personally, I have not looked for that particular feature as a diagnostic differentiator, but it's an interesting point. Perhaps I will start looking for it in the future.
Yeah, and it may reflect the ERG activation of some of those neoplasms as well. So, well, we've gone well over the time here, so I don't want to keep people a lot longer, but thanks everyone for participating, for good questions. We'll post the video of today's session shortly this afternoon, so that you can review it and share it with your students or friends. And again, we'll look forward to a future appointment with Dr. Murugan down the road here in the near future, so that he can continue this very excellent discussion and very important topic in managing and diagnosing bladder cancers. So thank you very much, and until we meet again, very good day to you all.
Thank you. Goodbye.